Welcome to Module 5, Introduction to Parenteral Nutrition. This module includes components from all chapters in the Aspen Parenteral Nutrition Handbook, and so there will be certain circumstances where you'll need to review the handbook for more details. As you might have guessed, in this module, parenteral nutrition is going to be introduced. We'll discuss when to use PN and appropriate IV access, and then we'll also go over how to write a PN order, and then we'll touch on PN dosing. This is a very abbreviated history of PN. For those of you who have been working in nutrition, you may take it for granted that we have always had PN. However, this really isn't true. In the 1960s, Dr. Stanley Dudrick, he realized that his patients with non-functioning GI tracts would basically die without adequate nutrition. The major breakthrough was in the late 1960s when Dudrick successfully infused beagle puppies with PN. Dudrick and colleagues, Vars and Rhodes, they were successful at providing PN to humans with a non-functioning GI tract and stimulated the idea that nutrition status played an important role in how patients fared postoperatively in regards to wound healing, complications, morbidity, and mortality. The latest advancement is the addition of lipids that contain more than just soybean oil. These new lipids, they contain MCT oil, olive oil, and fish oil. At this point, you now understand how to feed the patient that can tolerate oral or enteral nutrition. However, if the intake is inadequate and the patient cannot tolerate enteral feedings due to GI tract malfunction, then it's time for parenteral nutrition. This is often where there is hesitation. When using PN, intravenous access is required, and it isn't just placing a nasoenteric feeding tube or ordering double portions. PN is a viable component of the nutrition toolbox, and when a patient needs nutrition support and cannot tolerate it orally or enterally, then PN is indicated. It's still part of the nutrition toolbox. I know it looks dark and scary, but it really is a great resource, and it is some patients' only way to survive and get nourishment. Parenteral nutrition, or PN, is the provision of intravenous or IV nutrients to patients whose gastrointestinal tract is not functional or cannot be accessed. It is also administered to patients whose nutrition needs cannot be met with oral diets or EN, and it's recognized as one of the major medical advances in the past 50 years. Chapter 2 in the Parenteral Nutrition Handbook provides a nice overview. This definition comes from Aspen, and it says that parenteral nutrition bypasses the normal digestion in the stomach and bowel. It is a specialized liquid food mixture given into the blood through an IV catheter, which is a needle in the vein. The mixture contains proteins, carbohydrates, fats, vitamins, and minerals, and this special mixture may be called parenteral nutrition, total parenteral nutrition, or hyperalimentation. PN is reserved for patients who are unable to be fed enterally. If the patient has pre-existing malnutrition, it may be appropriate to initiate PN as soon as possible once the patient has been adequately resuscitated. Ideally, PN should be initiated in postoperative patients only if it is anticipated that the patient will need at least 7 days of nutrition support. Although a significant number of patients may need PN for a limited time in the hospital, some may need PN at home, which is home PN or HPN, to complete therapy or for a lifetime as total nutrition support. Both applications of PN we're going to talk about, and then some disease states that are common indications for PN include paralytic ileus, mesenteric ischemia, small bowel obstruction, a GI fistula, except where the enteral access may be placed distal to the fistula, or if it's a low output fistula, less than 200 mLs a day, that would support a trial of enteral nutrition. Those with chronic pancreatitis that can't tolerate enteral feeds, severe necrotizing pancreatitis, those with short bowel syndrome, ulcerative colitis or Crohn's disease, and those with intractable nausea vomiting, the EN trial has failed. Here are Aspen recommendations for starting PN. Ideally, we'd wait until 7 days have passed for the well-nourished adult and stable adults who have been unable to receive 50% or more of their estimated requirements orally or via EN. We'd like to initiate after 3 to 5 days for the nutritionally at-risk adult and those that are unlikely to achieve desired oral intake or EN. And then we want to be a little bit more proactive and initiate as soon as possible for those with baseline moderate or severe malnutrition in whom oral intake or EN is not possible or sufficient. And then we want to make sure, it's safe to initiate PN, so we delay it in those with severe metabolic instability until their condition has improved. Achieving hemodynamic stability, controlling blood sugar, and correcting major electrolyte abnormalities should all be done before starting PN. And the decision to start PN should include many parameters due to its risk and its cost. And clinical judgment is definitely needed here. We don't really just want to rush to initiate PN if we don't have to. Parenteral nutrition requires IV access, so PN may be infused via peripheral or central line. Peripheral PN often delivers less than adequate nutrients in a large volume because of the osmolarity constraints of the solution. Patients, they also have to have good peripheral venous access and be able to tolerate large volumes of fluid to receive PPN. Therefore, patients with renal, cardiac, or liver failure are often not good candidates for PPN. So most patients will actually have PN administered through a central line. And it's obviously always ideal to have a dedicated line for the delivery of PN. You don't want to be starting and stopping it for medications. And then at the hospital I work at, it's policy you have to have a dedicated line for PN. I'm sure you remember this diagram decision tree here from previous modules, but this time we're going to be focusing on the parenteral side of things. Parenteral nutrition access devices are covered in Chapter 3. The type of line is defined by where the distal catheter tip lies within the body and not where it enters the body. So central parenteral nutrition versus peripheral parenteral nutrition. For central, you obviously need a central venous access device, and it's defined as a catheter whose tip lies in the distal vena cava or the right atrium. And then peripheral parenteral nutrition, usually the tip is at the basilic vein. This is just a view of where the solution enters the body. However, this graphic does fail to depict a PICC line, which is a peripherally inserted central catheter. It looks similar to a peripheral IV, but we'll talk a little bit more about that later. So advantages of central parenteral nutrition: we have high blood flow. The line can stay in place for a long period of time. We can use hypertonic solutions, anywhere from 1700 to 2200 millimoles, to provide high calories and protein. And then we can meet almost any nutrient need with central parenteral nutrition. Disadvantages: it does require a procedure to place the line. There's a higher risk of complications. It's expensive. And you need a highly trained nutrition support team to be sure protocols of care are followed and outcomes are achieved. Advantages of peripheral parenteral nutrition include that no procedure is required to place a line. It's definitely cheaper than CPN and has a lower risk of infection than CPN. And it's not of high of degree of care is required. Disadvantages: short-term use only. Generally, we're using this less than 7 to 14 days. It's low blood flow, and it may be difficult to meet 100% of nutrient needs, especially if there are volume restrictions. It's less concentrated. You have to stay below 900 milliosms per liter, the osmolarity. And then if it's too concentrated, solutions are used, you'll end up with complications such as thrombophlebitis, sclerosis, or collapse of the vein can occur. Really, the two main reasons to not use PPN is when it's required for longer than the line can stay in the patient, and that would require replacing the line. And then it's very difficult or impossible to provide adequate nutrients because, if you remember, like I said earlier, you need a larger volume to keep below that 900 milliosm limit to get all your nutrients in. Now we're going to move into access devices. So a peripherally inserted central catheter or PICC line, they're very common in the hospital setting, and you can't actually easily determine what type of line your patient has based on the insertion site. However, a peripheral IV versus a PICC line are very different. A PICC line is a central line because the tip of the line is in the vena cava. The determining factor is where do the ingredients empty into the body. So if the tip is at the superior vena cava, subclavian, or near the heart, it is a central line. And these lines can handle higher levels of osmolarity, and you don't have to calculate osmolarity in these individuals. You should have no trouble administering all the nutrients you need through a central line. This slide just nicely depicts the locations for IV access, mainly focusing on long-term IV access. But the most common CVCs are subclavian, PICC line, tunneled line, such as the Hickman, Broviac, or Grosjean catheter. This is a subclavian catheter. You can find a similar figure in figure 3.3 in your parenteral nutrition handbooks. Non-tunneled catheters are the most common in the acute care setting. Like I said earlier, a PICC line, it's a peripherally inserted central catheter, and it's defined as a catheter inserted via the peripheral vein whose tip lies in the vena cava. These catheters are typically classified as non-tunneled CVCs, but tunneled PICCs do exist. They just can't be placed at bedside. The patient will have to physically go to IR for those tunneled lines. PICC placement is accomplished using the antecubital vessels, so the basilic, the cephalic, and the brachial vessels. This approach decreases the risk compared to a thoracic approach to catheter placement. PICCs have a lower incidence of infectious complications than tunneled catheters, but they appear to actually carry a higher risk for infection compared with tunneled catheters for patients who receive PN at home. PICC lines pose an increased risk for deep vein thrombosis, so DVT, compared with other types of catheters. And then a similar figure in your parenteral nutrition handbooks would be 3.4. The Hickman catheter is a long silicone catheter that is inserted into the large vein directly into the heart. This line is placed in the interventional radiology suite where a small amount of dye will be injected in the vein in the arm, and as the dye circulates from the arm veins into central circulation, x-rays will be taken. So for the procedure itself, a small incision is made on the chest for the catheter to exit onto the skin, which is the exit site, and then another incision will be made into the vein, the insertion site, and that the physician that they chose to insert the catheter at. A tunnel is made under the skin on your chest from the exit site to the selected vein. The tip of the catheter enters the superior vena cava, which is a large vein above the heart, and then the catheter is secured to your skin with a suture. And then you can look at 3.5 in your parenteral nutrition handbooks for a similar figure. A Grosjean CVC has a 3-position pressure-sensitive valve that restricts blood backflow and air embolism by remaining closed when it's not in use. When the valve is closed, it prevents blood from entering the CVC and clotting. So this eliminates the need for heparin flushes to maintain catheter patency. But the CVC should still be flushed with normal saline after medication administration or blood aspiration to ensure the valve is in the closed position. And this catheter may also be used for chemotherapy. This is a triple lumen CVC. You're most often going to find these in your super critically ill patients. Remember that 3 lumens equals 3 potential places for infection to occur. Even in the hospital, a triple lumen can be a challenge, and this type of catheter should absolutely not be used in home PN. Here's a simple table that kind of summarizes venous access devices. A much more detailed table can be found in Table 3.1, Selection of Vascular Access Devices for PN, in the Aspen Parenteral Nutrition Handbook. Now we're going to move on to the components of PN. Chapter 4 discusses this more in your Aspen Parenteral Nutrition Handbooks, but PN is composed of the macronutrients, which is your dextrose, your amino acids, and your lipids. You have your electrolytes, so sodium, potassium, magnesium, calcium, phosphorus, and then these can be given most often as chloride or acetate. And then we have vitamins, so vitamin C, vitamin A, D, thiamine, riboflavin, your B vitamins, vitamin E, biotin, folic acid, and then your trace elements, so your zinc, copper, chromium, manganese, and selenium, as well as a couple others that we can throw in there. Carbohydrates in PN are given as dextrose, and if you'll remember, dextrose has 3.4 calories per gram and not the normal 4 calories per gram that carbohydrates provide. The glucose infusion rate is the measure of the rate at which the patient receives IV administration of dextrose. So the recommendation is we try not to exceed 5 milligrams carbohydrate per kilogram per minute of glucose infusion, so GIR, for adult patients. Recommendation is 4 to 5 milligrams per kilogram per minute for adult patients and is actually less than 4 for critically ill patients. Calculation formula for GIR can be found on the PN worksheet as well as the next slide. And then note for GIR, recommendations are different in pediatric and patients in neonates. It's not uncommon to see GIRs in the teens for neonates. Too little dextrose can mean underfeeding, however, too much dextrose can be associated with overfeeding and negative effects such as hyperglycemia, increased minute ventilation, and therefore difficulty weaning from the ventilator, and hepatic steatosis. This calculation will calculate the maximum amount of carbohydrates that you can place in the bag. So for the purpose of this class, 5 is going to be the max recommended GIR for adults. However, in the real world, for stable, non-diabetic adult patients who will be going home on long-term TPN, you can push the GIR up to 7 as tolerated. But to calculate the maximum amount of carbohydrates you can place in the bag, you take 5 times their weight in kilograms times 1.44. So if you have a 65 kilogram patient, you multiply that by 5 times 1.44, and you can put 468 grams of carbohydrate. That would be the absolute max to put in the bag. And then remember that 4 to 5 milligrams per kilogram per minute is recommended for adults. Here's the calculation to calculate GIR, or glucose infusion rate. And so it's the grams of dextrose divided by the weight in kilograms divided by 1.44. So example, you have a 65 kilogram patient and they're receiving 468 grams of dextrose. It would be 468 divided by 65 divided by 1.44, which equals 5 milligrams of carb per kilogram per minute. Protein is provided in the form of amino acids. Levels of 0.8 to 2.0 grams per kilogram have been recommended based on disease states and tolerance. Even higher levels have been proposed in critical care for conditions such as traumatic brain injuries and continuous renal replacement therapy, but this requires close clinical monitoring. Glutamine is a conditionally essential amino acid, and it is a fuel for the enterocytes. It's not found in PN formulas because it is not stable in solution. Some data has suggested that it might be useful in patients with short bowel syndrome as a therapeutic intervention to promote bowel adaptation with growth hormone and a specialized diet in short bowel syndrome. But recently, the Canadian guidelines strongly advise against using glutamine in critical care due to poor outcomes. Patients with renal disease who need parenteral nutrition, they may be able to receive essential amino acids only in PN, but this is very rarely used, and I personally have not ever done that. Parenteral lipids are given in the form of injectable lipid emulsions, or ILE, and they're the source of essential fatty acids and calories for the person receiving PN. At least 10% of total calories should be provided from as lipids for adults to prevent essential fatty acid deficiency, or EFAD. This number comes from a paper by Driscoll, and it has been perpetuated, but I'm not sure that I've actually seen the clinical study that supports this. It may be in the lipids chapter in the core curriculum book. I do know that some of the newer lipid emulsions, such as SMOF lipids, they specify 13% as the recommended percentage of calories to prevent EFAD. Check with your pharmacist or your ILE supplier. Commercial lipids in the U.S., they're aqueous emulsions, and those that contain soybean oil also contain egg phospholipid, phosphorus, and vitamin K. And they're available in 10% solutions, which are 1.1 cals per milliliter, 20% solutions, which are 2 cals per milliliter, and 30% solutions, which are 3 calories per milliliter, and they're all isotonic. These soybean lipids, they should be avoided if there is a suspected egg allergy. And by the way, I just recertified for my CNSC, and this was a test question. A test dose can be provided and the patient closely monitored for tolerance if there is a concern. And then a test dose would be 1 ml per minute for 15 to 30 minutes. If there's no reaction, you can increase to the prescribed rate. Lipids are contraindicated with allergies to soybean or safflower oil products for people with pathogenic hyperlipidemia, acute pancreatitis accompanied by hyperlipidemia, which is very high triglycerides, and then anyone with a previous history of fat embolism. Lipids contain 7.5 millimoles of phosphorus per 500 ml, so this may be problematic if the patient has severe renal disease and they're not on dialysis. Lipids also contain vitamin K. The amount varies by the type of lipid, anywhere from 6 to 12 micrograms in safflower oil per 100 grams of oil and 150 to 300 micrograms in soybean oil per 100 grams of oil. Therefore, vitamin K that's given daily closely meets the recommendations. Monitoring international normalized ratio, so your INR, is important for your warfarin patients. The vitamin K in lipids and the multivitamin formulations will give the patient approximately 200 to 500 micrograms per day, depending on the amount and type of lipid that's added to the PN. Patients that are on anticoagulation therapy, mainly warfarin, aka Coumadin, who are initiated or discontinued on PN, this is important since this will change the amount of vitamin K being given and could potentially affect and result in changes in those INR levels. There are many other lipids available, from fish oil, structured lipids, and combinations that aren't even currently available in the US. But IV lipids should be administered from a 1.2 micron filter IV set. That was another question on my CNSE exam. And then for 2-in-1 solutions, the CDC recommends a 12-hour hang time due to the enhanced microbial growth potential. This is just a little timeline of advances in ILE, and as you can see, it is very recently that we have moved beyond lipids that include more than just soybean oil, starting with clinolipid in 2013. These are lipid injectable emulsions, and the top table is similar to table 4.1 in the Parenteral Nutrition Handbook. The bottom table comes from a video that's titled IV Lipids Update, What to Know and When to Use New Lipids on the Market. And then all the source of this data is from the manufacturers. Intralipid and Nutrilipid are soybean oils. Smoflipid is a mixture of soybean, MCT, olive, and fish oil. And the results of clinical studies indicate that Smoflipid is safe and well tolerated. Administration of the new emulsion demonstrated controlled triglyceride concentrations and well-preserved liver functions. Furthermore, Smoflipid infusion, it modulated fatty acid pattern in plasma and cell membrane phospholipids, and then a rise in the EPA and DHA-derived lipid mediators and maintenance of an adequate vitamin E status could be demonstrated, which resulted in favorable effects of the length of hospital stay in surgical patients that were receiving Smoflipid administered through a 1.2 micron filter set. Clinolipid is a lipid emulsion that contains a mixture of refined olive oil and refined soybean oil. And then the omega-3 to omega-6 fatty acid ratio in clinolipid has not been shown to improve clinical outcomes compared to other lipid emulsion products. Note that phytosterols, which are higher in intralipid and clinolipid, can contribute to intestinal failure associated with liver disease. Recommendations for parenteral lipids. So, although the package insert on lipids for adults says no more than 2.5 grams per kilogram, current practice usually limits IV lipids to 1 gram per kilogram per day, or about 25 to 30% of total calories, especially in critically ill patients. Lipids are generally limited to about 1 gram per kilogram per day to reduce the adverse effects of excess fat. Lipids have been reported to be immunosuppressive, but there was a study by Lesson, it was back in the American Journal of Clinical Nutrition from 1998, and it found that a lipid dose of 25-30% of total calories did not increase the infection risk in bone marrow transplant patients receiving PN. Serum triglycerides should be monitored for IV lipid tolerance. If triglycerides begin to rise, then the infusion rate should be lowered or stopped temporarily. If triglyceride levels are greater than 400, lipids should be withheld. If you're using a 2-in-1 solution, triglycerides should be less than or equal to 250 milligrams per deciliter 4 hours after infusion. Often critically ill patients are sedated, so if they're sedated with propofol, be sure to include the calories into your calculations. Propofol is a fat-based sedative, and it contains 1.1 calories of fat per milliliter. This is a table of suggested nutrient intake for adults receiving PN. It's table 5.2, and it's from your Aspen Parenteral Nutrition Handbook. And this is, of course, a starting point. Always use your clinical judgment. This is from the Aspen website, and it's a little bit more detailed than the last table from the handbook, and it includes some amino acid adjustments based on different conditions. I'm not going to spend time going through each and every one of these recommendations here. I'm not going to test you over specifically how many grams of protein should you dose in PN for critically ill trauma patients. That's not what I'm going to ask you on the test. This is really just here for you to help you in your practice when you're dosing parenteral nutrition. Here are recommendations for neonates and pediatric patient. Note in the peds world, things are dosed and expressed differently, usually in terms of grams or milligram per kilogram. Once again, here's this table with different methods for calculating fluid requirements. I've never used 3 or 4, but the majority of adults can meet fluid needs with number 1, which is 1 ml per kcal, or number 2. Once the macronutrient tolerance has been established with the PN, the routine management of fluid and electrolytes also needs to be established. When determining fluid and electrolyte status, first we want to evaluate any concurrent IV fluids and medications provided along with the PN therapy. All fluids being infused should be considered when the PN formulation is prescribed. If the patient has excessive losses, fluid and electrolyte replacement with separate IV fluids outside of the PN may be necessary. In general, though, you should be able to meet fluid needs through PN alone. A good resource is the Aspen Nutrition Support Core Curriculum, the 3rd edition. Chapter 17 goes over complications of parenteral nutrition and its micronutrient-related complications and fluid and electrolytes. We want to follow the same fluid guidelines that you had for enteral nutrition, taking into consideration the patient's condition. Very muscular, active individuals will likely require more water than in the volume estimated by these equations because they have an increased percentage of lean body mass. Regardless of the method used to determine fluid needs, the fluid volume must be adjusted regularly based on fluctuations in intake and output, as well as the patient's clinical status. PN additives include electrolytes, multivitamins, trace elements, and fluid. This is a nice reminder of where key nutrients are absorbed in the GI tract. If your patient has lost part of their GI tract, it's important to know these absorption sites because this will help you predict potential deficiencies. So, for instance, if your patient has short gut, they're at much greater risk for vitamin deficiencies than someone who requires short-term PN because of an ileus. Here's the standard dosing of electrolytes for the pediatric populations. You can see the asterisk at the bottom. It says use caution in prescribing calcium and phosphorus related to compatibility. We'll talk a little bit more about calcium phosphorus solubility in Module 6. Here's standard electrolyte dosing per Aspen. For calcium, most often in parenteral nutrition solutions, it's going to be in the form of calcium gluconate. And the standard daily requirement is anywhere from 10 to 15 milliequivalents. Factors that may increase your needs if you have a really high protein intake. For magnesium, the standard form is magnesium sulfate, and then the daily requirement is usually 8 to 20 milliequivalents. Factors that could increase needs would be GI losses, certain medications, or if the patient is refeeding. Phosphorus comes in sodium phosphorus and potassium phosphorus. Standard daily requirement is 20 to 40 millimoles, and factors that increase needs would be a high dextrose intake or if the patient is refeeding. So phosphorus, for sodium phosphorus, for every millimole of sodium phosphorus, there is 1.33 milliequivalents of sodium. So if you have 20 millimoles of phosphorus, sodium phosphorus, then you multiply that by 1.33, and that will tell you how much sodium comes in that sodium phosphorus dose. Same goes for potassium phosphorus. So for every millimole of potassium phosphorus, there's 1.47 milliequivalents of potassium. So same thing, if we have 20 millimoles of potassium phosphorus, we multiply that by 1.47 to get the amount of potassium that's given. For sodium, it comes in sodium chloride and sodium acetate. And then which one you use depends on the patient's needs for acetate or chloride. And standard daily requirement for sodium is 1 to 2 milliequivalents per kilogram. And then factors that could increase needs would be diarrhea, vomiting if they have high NG output, or high GI losses. Potassium comes in potassium chloride or potassium acetate. And like I said earlier, it's also found in potassium phosphorus. Standard daily requirement is going to be anywhere from 1 to 2 milliequivalents per kilogram. And factors that could increase needs would be diarrhea, vomiting, high NG output, GI losses, certain medications like potassium wasting medications such as Lasix, or patients with refeeding syndrome. And then acetate and chloride, like I said, the forms of the other electrolytes that you use, whether it be potassium acetate, potassium chloride, sodium acetate, you'll use those as needed to maintain acid-base balance. So a patient might need more acetate if they have renal insufficiency, metabolic acidosis, if they have high GI losses of bicarb, and then patient might need more chloride in metabolic alkalosis and then volume depletion. This is a table of what is considered high and low doses of electrolytes. Keep in mind that PN is very individualized to the patient, so even though something may be considered a low dose, it may be very appropriate if the patient has any kind of degree of renal impairment. Then we're also monitoring for acid-base balance. We're looking at those ABGs, or arterial blood gas labs, and looking for actual serum pH, and then looking at everything to determine if they have acidosis or alkalosis. This table summarizes the dosage form of the electrolytes. The various types of electrolyte forms, they'll help you with your PN dosing and balancing acid-base. Remember for sodium phosphate that 1 millimole of sodium phosphate has 1.33 milliequivalents of sodium. And for potassium phosphate, 1 millimole has 1.47 milliequivalents of potassium. So an instance where this will help you with dosing is, let's say a patient has a phosphorus on the lower side, but their potassium's 4.5 or greater. Then in that case, you would be more likely to choose sodium phosphate for your phosphorus dosing, and then you can control the potassium dosing using potassium acetate or potassium chloride. Whereas if a patient has need for both potassium and phosphorus, you might use potassium phosphorus to help simplify dosing. Everything that we just talked about for electrolyte dosing, remember that these are very general guidelines. It's a good place to start, but each patient should receive individualized electrolytes based on their clinical status and diagnosis. So frequent adjustments, they may be necessary depending on whatever changes your patient has in their clinical condition. Make sure you count for abnormal losses like fistulas, diarrhea, high NG output. And then remember that the addition of electrolytes affects osmolarity, which is especially important when we're dosing PPN. It's going to be very hard for you to give a lot of sodium in a PPN because we have that osmolarity limit to be aware of that has to be less than 900. So how do we calculate the osmolarity for PPN? So each individual component here, they're going to affect the osmolarity differently. Note this is for adults only. But for amino acids, you're going to take however many grams of amino acids, you're going to multiply it by 10, and then you're going to divide that by the total volume in liters. And for dextrose, it's going to be multiplied by 5. For lipids, 1.3. Note that lipids, they affect osmolarity the least out of all the macronutrients. So you're going to be able to fit more lipids in a PPN compared to dextrose and amino acids. And that's okay to provide calories, especially PPN should be short term. So it's okay to provide a little bit more calories as lipids until we can get that central line placed. For sodium chloride, you'll take the milliequivalents times 2, potassium chloride times 2, and calcium gluconate times 1.4, and magnesium sulfate times 1. And then you'll remember to divide by the total volume of PPN in liters. And then all of this has to add up to less than 900 because 900 is the maximum osmolarity for PPN. So here's a table from Aspen that depicts the daily requirements of adult parenteral vitamins. Most of the time when you're dosing vitamins in TPN, it's just a standard daily multivitamin that's added. You're usually not dosing each individual vitamin. You can, but most often we're just going to throw in the standard multivitamin. Here are the Aspen recommendations for daily multiple vitamin product dosing for the neonate and pediatric populations. This is for the multivitamin products Infuvite Pediatric and MVI Pediatric from Hospira. And this is the manufacturer recommendations versus the Nutrition Advisory Group American Medical Association recommendations. Here are daily trace element requirements if you're for adults if you're dosing them individually. However, most of the time you'll be using a multi-trace element product in your TPN dosing, and then sometimes you do have to throw in um, an extra individual component if the patient's found to have a deficiency. For instance, like right now, I have a long-term TPN patient who has short gut, and she hadn't been receiving the standard multi-trace packet because of a reported allergy. And then we drew her trace elements most recently. Copper came back low, so now she was agreeable to trying the standard multi-trace element packet, and so far no adverse reactions or anything like that, but I'm also giving an extra copper dose for repletion on top of that. Here's a comparison of two multi-trace element products, MTE5 and Trailment, and note that all these dosages are per 1 ml. So 1 ml of MTE5 has 5 milligrams of zinc, 1 milligram of copper, 0.5 milligrams of manganese, 10 micrograms of chromium, and 60 micrograms of selenium. And then here is the trace element daily dosing for your pediatric population. So your preterm neonates, your term neonates, children that are anywhere from 10 to 40 kilograms, and adolescents that are greater than 40 kilograms. And again, I'm not going to test you on this specifically, but I want you to have these resources for those of you who are going to be working with or are already working with pediatric populations and you're dosing their TPN. Now we're going to move on to parenteral administration. So parenteral solutions are compounded by a pharmacist using a clean room. A total nutrient admixture, which is a TNA, or it's a 3-in-1 solution, and it contains the dextrose, amino acids, lipids, and the additives, and they're all mixed together in one container. It'll appear like a white, creamy liquid. The drawback to this is that you will not be able to identify any kind of precipitates in the solution. And you can see table 6.1 in your parenteral nutrition handbooks for advantages and disadvantages of the total nutrient admixture system. So a 2-in-1 bag only contains dextrose, amino acids, and the additives. Lipids are going to be delivered separately or not at all if lipids are being withheld. And then if lipids are being delivered separately, it's often referred to as piggybacked, and they're given either daily or intermittently. And then the lipids will have their own pump, and they can infuse for shorter hours if needed than the dextrose and amino acid solution. And then the 2-in-1 product is going to be clear or yellow if it has the multivitamin in it. And that way the advantage to this is that it is easier to identify any precipitates in the solution. And then we're going to talk more about precipitates in the next module when it comes to complications. And here's just an illustration of a 2-in-1 and how lipids are piggybacked separately. So you can see the 2-in-1, it has the dextrose, amino acids, electrolytes, water, and the vitamins and minerals. So that's all in one solution, your main solution, and then you have the lipids by themselves that are given separately. So PN can either be compounded by the pharmacy or it can actually come as a commercially prepared IV nutrition mixture. For a pharmacy compounded bag, this allows complete flexibility of the content, and it's sometimes called customized PN, but you get to control the volume, the macronutrients, electrolytes, vitamins, minerals, etc. It is state regulated, laws vary by the state, and then they follow very strict compounding standards, and there's no final sterilization or batch testing required. For a commercially prepared bags, they come in several preset mixtures, and they're meant to be used without too many additional additives besides vitamins and trace elements. If electrolytes need to be added in the hospitalized patient, it may be better to do this using a separate IV preparation. But they have multi-chamber bags available. These products are produced by pharmaceutical companies. They are regulated by the FDA, and they're commercially manufactured. They follow good manufacturing standard practices. They are terminally sterilized, so and final before they're sealed in the container. And then expiration dating extends beyond the pharmacy compound dating. And then in some incidences, the addition of additives might be needed. So for multi-chamber bags that are commercially prepared in the U.S., there are two manufacturers that market these products, and it's Baxter and Cabevan. Usually, commercial PN solutions are often used in smaller facilities that do not have the ability to compound. Dietitians, we still need to look very carefully at these solutions and note what is included in the bag, just as we would for a compounded custom mixture. Vitamins and minerals and sometimes even electrolytes need to be added for these patients. They can be added in another IV line. And these bags are not intended for long-term use, and they're definitely not appropriate for patients who are critically ill. They are manufactured using good manufacturing practices, and so therefore that may improve safety as well as quality controlled, and it reduces sources of contamination versus a compounded product. That doesn't mean that compounded products, the pharmacy just willy-nilly throwing stuff in there. They have their own safe practices and clean techniques that they use too. But the idea is that good manufacturing practices, they're manufactured in a place to prevent subpotency or superpotency, contamination, unpredictable safety or efficacy, and misbranding. I believe it's chapter 12 that discusses multi-chamber bags in a bit more detail. And then on Blackboard, there's a brochure on Clinomix. It's Clinomix E solution that actually contains electrolytes. Note that the other Clinomix solutions do not contain electrolytes. So those are there for you for your resource if you need them. Here's an illustration of a two-chamber bag that contains dextrose and amino acids versus a multi-chamber bag that has dextrose and amino acids and lipids, and this particular example also has electrolytes that are already all pre-mixed. So it provides a constant amount of amino acids, dextrose, and a baseline electrolyte profile for easy standardization. As I said previously, follows those good manufacturing practices, so could be improved safety and quality component there, and could help reduce sources of contamination versus a compounded product. And this will contain more of a moderate level of electrolyte since it is standardized, and still, remember, we still have to add the vitamins and the trace elements. And here's a table just that has a comparison of two different multi-chamber bag products and what they contain. So here's a decision tree for custom versus standardized PN solutions. I said this before, but commercial parenteral nutrition solutions are often used in those smaller facilities that do not have compounding capability, and as such, they tend to have a bit lower acuity patients as well. Once again, RDs, you need to look very carefully at these solutions, note what's in them, just as you would pick out custom components for a customized compounded mixture. These are not intended for long-term use, and they are contraindicated in the following conditions. So renal failure, especially if they're on dialysis, congestive heart failure, where there may be volume restrictions, severe liver disease and hepatic coma, metabolic disorders that are associated with impaired nitrogen utilization, and hypersensitivity to one or more amino acids. In your facility, you might not have a choice. My hospital only does custom compounded TPN, but we're also a larger facility. We have a very high level of acuity. Always remember to use your clinical judgment. Here's just a comparison of standardized solutions versus customized. So on the left-hand side, you have your standardized solutions. So PN formulation intended to meet the daily maintenance requirements of a specific patient population. That's for age, stress, or disease state specific, and is differentiated by the route of administration, central versus peripheral vein. It's a standard commercial PN product. It's a standardized PN, and the formulation is available from a manufacturer, and it requires fewer compounding steps before administration. For a customized compounded solution, it gives the ability to individualize the nutrient mix as well as the electrolyte content, and it's good for patients whom standard PN may be difficult to use. So, like I was saying earlier, those with renal, hepatic, or other organ compromise, individuals that are at risk for refeeding syndrome, those that have issues with glucose intolerance, for neonatal and pediatric patients, you're going to want to use custom TPN. Adults that have abnormal body composition, where maybe it's bariatric patients who need higher levels of protein and less amounts of dextrose. Um, Large GI fluid losses, that are critically ill, should really be using custom PN. And then home PN patients that demonstrate large volume fluid and electrolyte losses to where the standard just isn't going to cut it. So for PN administration, a continuous infusion is usually a 24-hour infusion. It's helpful for diabetes, renal, or cardiac diseases. And then individuals at high risk for refeeding syndrome may also benefit from continuous infusion initially. Pretty much every new start TPN patient is going to start out with a continuous 24-hour infusion. And then you start cycling once the patient is at goal and is tolerating. Fluid tolerance may be better with a continuous infusion in certain patients, and your hyperemesis patients may also feel better initially with a continuous infusion. Cyclic PN administration is typically a 10 to 16 hour infusion, and we're trying to mimic the circadian cycle of eating and fasting. It may increase the risk of metabolic bone disease. Cyclic PN favors a urinary calcium excretion, but it may reduce hepatic complications and it may improve quality of life. When you start cycling, you'll begin when the patient has demonstrated tolerance to the final solution and rate, and then you'll compress the infusion period by anywhere from 2 to 4 hour increments, and you'll reach goal hopefully within 2 to 3 days. You are going to want to taper PN at the start and end of the infusion, and then we want to monitor glucose. So it can be a day or nighttime infusion depending on the patient's preference. Patients may be discharged from the hospital on a 24-hour infusion rate, and then the home infusion company can cycle to help enhance quality of life, and then while optimizing discharge practices and reducing hospital length of stay. Here's just some guidelines for transitional feeding. We want to maintain full PN support until the patient is tolerating greater than 60% of their estimated needs via the GI tract. We can decrease PN by 50% and continue to taper as the enteral feeding is advanced to goal if the patient is transitioning to enteral feeds. PN can be rapidly discontinued if the patient is receiving enteral feeding in an amount great enough to maintain blood glucose levels. If you cut off PN immediately and the patient isn't taking in much via the GI tract, that could cause hypoglycemia. So PN can reduce appetite if greater than 25% of the calorie needs are met via PN, so that's something to consider if we're transitioning from PN to oral feeds. And then PN can be tapered when the patient is consuming greater than 500 calories per day by mouth and discontinued when we're meeting greater than 60% of our goal calorie needs. So rebound hypoglycemia is a potential complication when we're stopping the TPN or the infusion of dextrose. We want to avoid it by decreasing the rate by 50% for 1 to 2 hours before discontinuing the solution to help minimize the risk. So now we're going to get into calculating what's in the bag and writing our own PN orders. I'm going to go through an example and how to do all these calculations. And then you can also refer to how to write a PN order for further information. So writing a PN order requires knowledge of nutritional requirements, interaction of nutrients within the formulation, and implications of diseases and metabolic disorders on nutrient metabolism. This is not an entry-level skill. This is an advanced practice thing. And it looks really scary, and that's okay. We're going to try and tackle it step by step here and at least get you a baseline knowledge. But really, the best way that you guys are going to learn is by doing it in your practice. For the purposes of this class, we're going to focus on the macronutrients. We're not going to worry about dosing individual electrolytes for the test or for the assignments or anything like that. But let's get into it. So Step 1, we're going to calculate the volume of amino acids needed to meet our calculated needs. Step 2, we're going to calculate the volume of lipids for the PN formula. And don't forget to account for any propofol if your patient is receiving this sedative. Step 3, we're going to calculate carbohydrates to complete the PN formula, the macronutrients. Step 4, if this is a PPN, we're going to calculate the osmolarity to make sure it's less than that 900 milliosms per liter, and then we'll make any adjustments if necessary. Step 5, we want to determine the volume of PN to be provided. So this is where we add additional sterile water to meet 100% of our fluid requirements. Fluid volume management, we're going to use it based on estimated body weight. So if you remember, maintenance fluid requirements are 30 to 40 mLs per kilograms for most adults. For adults that are age greater than 65, we're going to use 25 to 35 mLs per kilogram. We're going to want to add fluid to account for any other losses, such as high output fistulas, ostomies, if patient has significant diarrhea or emesis. Step 6, we're going to add electrolytes. So, like I said, for this purposes of this class, we're not going to do electrolyte dosing, but in the real world, be aware of your calcium phosphate stability, which we will talk more about that in Module 6. Step 7, we're going to add our standard multivitamins and any trace elements for specific needs. Ideally, we're just going to use the multivitamin preparations and the trace element packets. Occasionally, you might have a patient who needs more or less of a vitamin or mineral, but as a general rule, stick to the packets. And then step 8, we're going to add additives such as H2 receptor blockers or insulin. And then step 9, determine the infusion rate. We're going to go through these calculations using this patient X as an example. They are 70 kilograms, their calorie needs are 2,200 calories, their protein needs are 105 grams of protein, and their fluid needs are 2,200 mLs. We're using 70% dextrose concentration, 12.5% amino acid concentration, and 20% lipids. And then, like I said, for the purpose of this class, we're going to focus on that macronutrients and volume. You do not have to dose individual electrolytes. We're just going to use the collective term additives to incorporate into the total volume. Additives typically account for about 100 mLs of volume, so that's what we're going to use. To determine the volume of amino acids to add to the formula, we're going to take the required amount of protein grams and we're going to divide it by the concentration of amino acids times 100. So our patient needs 105 grams of protein. We know it's a 12.5% solution, so we're going to take 105 grams divided by 12.5, multiply that times 100, and then you have 840 mLs of 12.5% amino acids. So then you're going to take the grams of amino acids times 4 calories per gram, and that's going to give you how many calories that come from protein. So 105 grams amino acid times 4, that's 420 protein calories. Next, we're going to determine the volume of lipids to add to the formula. We want to provide anywhere from 25 to 30% of total calories as lipids, or less if there's hyperlipidemia. So we're going to start with 30% of 2,200 calories, so 0.3 times 2,200 equals 660 calories. We're using 20% lipids here, that's 2 calories per ml. So we're going to take 660 calories and we're going to divide it by 2, and that's going to give us 330 mLs of 20% lipids. Then you're going to take that mLs of lipids times the concentration of lipids to give us the number of grams of lipid in the PN formulation. So 330 mLs times 0.2 equals 66 grams of lipid. The shortcut for grams of 20% lipids is total lipid calories divided by 10. So if you have 660 calories and you're divided by 10, that gives you 66 grams of 20% lipid in a PN formulation. And then don't forget to factor in propofol calories. In this particular example, our patient is not critically ill and they're not requiring sedation. Now we're going to determine the volume of carbohydrates to add to the formula. So we take the number of calories from protein plus the calories from lipids, and then that's going to give us the total calories of protein and lipid combined. So 420 calories from protein plus 660 kcals from lipids. That gives us 1,080 calories. So we take the total required calories and we subtract the number of calories provided by protein and lipids. So 2,200 minus 1,080 gives us 1,120 calories left to provide in the form of carbohydrate. So we take the remaining calories and we divide by 3.4 to give us the grams of dextrose. So 1,120 divided by 3.4 gives us approximately 330 grams of dextrose. Then you take those grams of carbohydrate and you divide by the dextrose concentration times 100 to give us the volume. So we have 330 grams of carbohydrate divided by 70 because 70% carbohydrate solution, and then we multiply by 100, and that gives us 471 mLs of 70% dextrose. Next, we want to determine our glucose infusion rate to ensure that we're not giving too many carbohydrates. So remember, this is expressed as milligrams per kilogram per minute. So you take the grams of dextrose in the bag divided by the patient's weight in kilograms and then divide that by 1.44. So we have 330 grams of carbohydrate divided by 70 divided by 1.44, and that gives us 3.27 milligrams per kilogram per minute. And remember that ideally we're keeping the GIR below 4 to 5, and this fits the bill. To determine the volume of sterile water that we need to add to the formula, we take the required fluid volume minus the sum of protein, lipid, dextrose, and the additives, which remember that's 100 mLs. So we take 2,200 minus 840 plus 330 plus 471 plus 100, and that's going to give us 459 mLs of sterile water that we need to add to meet fluid needs. Alright, now we're going to calculate the osmolarity. This is really only important for ppn, but you're going to take the grams of carbohydrate times 5 and then divide that by the total volume in liters, and then you're going to add that to the total grams of amino acids times 10 and divide that by the total volume in liters, plus the grams of lipids times 1.3 divided by the total volume in liters. So we have 330 grams of carbohydrate, multiply that by 5, and then divide it by 2.2 liters. Then we have 105 grams of amino acids times 10, divide that by 2.2, and then 66 grams of lipid times 1.3 divided by 2.2. So we get 750 plus 477 plus 39. That gives us an osmolarity of 1266. Remember that the maximum osmolarity for ppn is 900 milliosmoles per liter, and so therefore this formulation is not acceptable for a ppn. You're either going to have to increase the volume or take out some macronutrients to make this fit for a ppn. Now we're going to determine the rate of infusion by taking the total volume divided by the hours of infusion. This is a new start TPN, so we're going to run a continuous infusion over 24 hours. So we take 2,200 mLs divided by 24, that gives us 91.67, or in reality, we're going to run this at 92 mLs per hour. The last thing we need to do is check the balance of nutrients. So we want to be sure that we have a balanced bag. So we're going to take the protein calories divided by the total calories to give us the percent of protein calories. So we have 420 divided by 2,200, and that leaves us with 19% of calories provided by protein. Then we're going to take the lipid calories and divide them by the total calories. So we have 660 divided by 2,200, and that's 30%. And then we take our dextrose calories divided by the total calories to give us our percent calories from dextrose. And so it's 1122 divided by 2,200, and that's 51%. And there you have it. That's your PN calculations. This is the same example that's shown on the How to Write a PN Order form on Blackboard. And so you can refer to that in these lectures as necessary. Here is an example of a standard order for adult template for a 3-in-1 admixture. There's also a PN order template in Figure 5.1 in your Parenteral Nutrition Handbook. And here's a template for injectable lipid emulsion to be ordered separately, like with a 2-in-1 solution. Most everything is done electronically now, but you'll still see similar forms in the outpatient setting, and they often get faxed or scanned into the electronic medical record. Remember back in Module 4, there was an enteral nutrition care pathway from Aspen. There's also one for parenteral nutrition, and the link is in Module 5 in Blackboard. Be sure and review this pathway. It is absolutely an excellent resource to keep and use for your future careers. Well, there you have it. This is the end of parenteral nutrition introduction. Looking ahead to Module 6, we're going to talk about complications of parenteral nutrition. That was a lot, so thanks for staying with me, and look forward to seeing you guys next time.